Hello, everyone, and thank you for joining today's UC Irvine Age-Friendly Geriatrics Education Tele-ECHO series on mental health. Today's session is going to be focusing on mobility and mental health in older adults. The purpose of this session is to provide an overview of mental health issues in older adults and the effects of depression on mobility. Today's objectives will focus on how depression impacts mobility in older adults, how changes in mobility and function can increase the risk of depression in geriatrics patients, and how medications used to manage mental health issues can impact mobility and fall risk. The target audience is you all and any other healthcare professionals with an interest in the care of older adults. This session is accredited by the ACCME to provide a continuing medical education for physicians, and the CBRN also recognizes CME credit as transferable for their members. Nurses may receive CEUs after submitting their UC Irvine attendance certificate directly to their board. This is our agenda for today, and we're going to be starting with welcome announcements and introductions, following our didactic presentation on mobility and mental health. And then we'll move on into our patient case and discussion, and then we'll end with our any closing or reminders. Just as a reminder, please be sure to mute yourself when you're not speaking to prevent background noise, and introduce yourself when you're speaking with your name and location. Since we do have case presentations, we always want to make sure that we are maintaining confidentiality and that you do not include any personal health information of your patients in the case discussion. This session is being recorded, so your participation does confirm your consent to this recording. This project is supported by the Health Resources and Services Administration, and information or content and conclusion are those of the author and should not be construed as the official position or policy of HRSA, HHS, or the U.S. government. Our faculty do not have any financial disclosures at this time. Then we're going to go ahead and move on into introductions. If you are on your computer, please go ahead and use the chat function to let us know your name, your role, your site, and your location. And we'll go ahead and move on to our hub team, who will introduce themselves. My name is Nika Seville, and I'm the project manager for our Geriatric Workforce Enhancement Program, and I'm located at UC Irvine Health in Orange County, California. Dr. Gibbs?
Yes, hi, welcome everybody again. Dr. Gibbs, I think we met before, but if there are any new people here, I'm the Chief of Geriatrics at UCI, and welcome.
Thank you, Dr. Sagal.
Hi everybody, I'm Sonia Sagal. I'm a clinical professor at UC Irvine in the Division of Geriatrics, and my practice site is in Orange. Welcome.
Dr. Gerbich.
Hi, Tanya Gurvich, clinical pharmacist. I'm a professor at USC Pharmacy School, where I teach geriatrics curriculum, and my practice site is at UCI Senior Health Center. Hello.
Thank you. Is Camille here?
Yep. Hi, everybody. This is Camille Fitzpatrick. I'm a geriatric nurse practitioner at our Family Health Center in Santa Ana, and I'm a professor of nursing at UCI. Welcome back, everybody.
Thank you. And Carlos?
Happy Friday, everyone. My name is Carlos Garcia, and I'm the web data analyst. Welcome.
Thank you all. And it looks like we have a lot of our folks on the line. I see RN Langley, I see Dr. Hooby, and I see quite a lot of other people in the chat. So thank you all for joining today. We're going to go ahead and move on into our didactic presentation for the day. And that, again, is going to be focusing on mobility and mental health by Dr. Sagal and Dr. Gerbich today. So we'll go ahead and get started.
Thank you, everyone. It's our pleasure to talk about mobility and mental health today. Our objectives are going to be to discuss how depression impacts mobility in older adults. We'll review some of the immobility and function that can actually increase the risk of depression in our geri patients. And I think it's important to focus in on these so that if you do see these changes as you examine and interview patients, good to think about screening. And then we'll discuss how medications used to manage mental health issues can actually impact mobility and fall risk, and strategize ways to overcome that. Next slide. So let's have a brief review on the hallmark features of depression. And I'm sure that you've all heard about the SIGI CAPS mnemonic that we use. And of course, we'll just go over this very briefly. So folks who have depression or depressive symptoms can have alterations in their sleep. They may be sleeping a lot more and spend a significant portion of their day sleeping or in bed, but they also may not be sleeping very well and have early morning awakenings and disrupted sleep patterns. In terms of I, so their interests and their personal interests can be impacted, and they can display anhedonia or diminished interest in things that they used to or previously enjoyed. And this can lead to a significant degree of isolation if they were once very socially active. They can have symptoms of guilt and feelings of worthlessness. They may experience decreased energy, and this can impact their day-to-day functioning, their activities of daily living, and just getting through the things that one needs to do to function in their life. They can have issues with concentration, which can impact their ability to acquire and consolidate memory. They can have changes with appetite and weight change. So these folks can stop eating or eat a lot less, and some of them can actually eat a lot more. And so if we see significant change in their weight in any direction, we do get concerned about depression. P, psychomotor agitation or retardation, and we'll spend a little time talking about that in just a minute. And then of course, suicidal ideation, one of the more severe features of depression. Next slide. So if we take a look at these hallmark features of depression, you can see that half of them actually can impact mobility and motor functioning. So if you don't sleep well, you can, if your sleep is disrupted and you're not sleeping, you may wake up or be awake the next day, stumble and fall. If you're sleeping too much, maybe, or you're staying in bed too much, maybe you become deconditioned, and that can increase your risk of falling down. If your interests at one point were to be active, engaged, maybe you were taking a walk and you become depressed and these things diminish, your interests diminish, that could lead to immobility and increased risk of falling down. Same with the decreased energy. And then psychomotor agitation or retardation, big time motor symptom. Next slide. So let's talk a little bit about psychomotor retardation. So what is it? We hear the term when we're learning about depression, and we see it in SIGI CAPS, but I think it's good to just review the features of psychomotor retardation. So this is a slowing of movement, thought, and affect that can plague folks who have depression. And the more severe the depression, the more striking these findings can be. These folks can have slowing of their hands, legs, torso, and head. Their movements, their gross motor movements are just slower. So if you hand them a piece of paper, the movement, the reach to grab that piece of paper might be slower. As your staff are bringing the patient back to be roomed, their gait speed might be slower. Their overall movement is just impaired. These folks can also have a stooped posture, poor eye contact, and their speech can be affected. So, and the speed of their speech and the volume of their speech can both be diminished. And then they can have a flat expression or flat affect. So psychomotor retardation, really this overall slowing of movements, thought, and affect. And along with the slowing of the motor functioning, their thought process can be impaired and slowed. So maybe you ask your patient a question, and whereas at one point they would be able to very fluidly answer you, there is a delay. They hear the question, there's a delay, they think about it, and then give you a response back that is slowed. Next slide. So as I mentioned before, the more severe someone's depression, the more severe the motor impairment might be. And in a very, very severely depressed patient, we can sometimes rarely see catatonia. And this is an inability to move normally. The patient may be laying still and their speech may be very impacted to the point where they lack speech altogether. And I actually right now am managing a patient with severe depression, and it's manifesting as catatonia. So where this person was very functional in their day-to-day life, driving their car, working part-time, interacting with family, due to a severe depression that has gone on now for over 6 months, this person basically is in bed, or with prompting of family will move to the couch in their home. He does not speak, despite having multiple family members try and converse with him. The family does have some understanding that he's receiving the information and the conversation that they're having, but he is unable to fluidly respond back. He can occasionally respond back in 1-word or 2-word phrases. And he is, for all intents and purposes, very still and slow in his movement. So almost overnight, he went from walking and driving to not having the ability to do those things. And he has been evaluated for cognitive impairment and dementia, and that has been ruled out. And this is thought to be a catatonic severe depression. Next slide. Now, in patients who are depressed, of course, due to the symptoms that we talked about and dissected earlier, activities of daily living can be impaired. And not everyone is impacted to the degree that my patient with catatonia is, but even patients with very mild depression or moderate depression, like we talked about, can have issues with walking and feeding, dressing, all slowed, all impaired. Maybe there's a lack of motivation, so they're not so interested in dressing or grooming or bathing. And we can see these changes in folks who are expressing depressive symptoms. Next slide. One thing I wanted to mention briefly is that, there's an interesting paradox. So people who are not depressed but lose their ability to conduct activities of daily living, they're at high risk for depression. So the impact of mood and ADLs, it goes back and forth. So people who are depressed can have impaired ADLs, but people who are not depressed and have for some reason developed an inability or difficulty in managing their day-to-day life are at increased risk for depression. So we look at that very closely. Now, as you know, there are many medical disorders that increase the risk for someone to develop depression or depressive symptoms. A few of those are listed here. So diabetes, stroke, CAD, hip fracture, or frailty. These conditions can all impact one's ability to be mobile, whether it be due to a neuropathy or shortness of breath or dyspnea, or simply lack of motor coordination or movement or strength due to a stroke. And then, of course, there are other medical conditions like Parkinson's disease, dementia, which can increase the risk of depression as well. Next slide. Now, over time, a lack of activity increases a patient's risk for falls. So we know this is true for our patients who are not depressed, but probably even more for those who are. And sadly, over the course of the past year, we've seen a significant number. I have in my patient panel of folks who have lacked activity due to the pandemic. So either being unable to attend a senior day program, a senior center, an exercise class, simply being afraid to go out into their community to take a walk. We are seeing a great deal of deconditioning and falls. Next slide. I'm going to just touch a little bit on some facts about falling, and I think you're all familiar with how common falls are. So upward to 25% of adults have experienced a fall, but less than half actually report these falls to their doctor or medical provider. I think it's important for us to really screen for this. I know clinics have processes where patients are asked on a routine basis if they've fallen or sustained an injury, and that information can then be relayed to the medical provider to ask further questions about that. And when I ask my patients about why they aren't telling me that they've fallen, they just simply think it's, they don't really think anything of it. They feel like, well, it was a minor issue. Some of them are a bit embarrassed to say that, and many are concerned and worried that we might find that they need an assistive device, such as a walker or a cane, which does carry some stigma. Each year, approximately 3 million older adults go to the ED for falls. There's a significant medical cost associated with falls and complications related to these falls. A significant number of hospitalizations, and of course, particularly in our older adult population, the vast majority of hip fractures are caused by a fall. And these falls can involve very little trauma. Actually, at the Senior Health Center, I've had patients who have fallen and have walked in with hip pain, and they walk in with hip pain. We do an X-ray, and they've actually fractured. I've had a patient who was very, very active actually fall backwards as he was because he lost balance as he was taking a kayak off the roof of his car, and he shattered his hip. And recently I had a lovely lady who was walking her 5-pound puppy, but got tangled in the leash and fell and sustained a fracture. Now, the after effects of these falls can be quite devastating. So the patient who I mentioned earlier, who fell getting the kayak off of his car, was actually fairly young and very robust and very active. But after he sustained his hip fracture, due to some complications, he ended up with a 5 to 6 inch leg length discrepancy, and he's never really recovered his pre-fracture mobility, and in fact has developed significant back pain and required the use of opioid medications to control this due to this complication. Falls are a very common cause of a traumatic brain injury, which can lead to significant devastation for a patient and their life and loved ones. So again, falls very common, and I think it's on us to really screen our patients for this. Next slide. And I've touched on the consequences of falls. So of course, fracture, reduced mobility and pain, head injuries can lead to cognitive impairment, and overall a decreased quality of life, isolation, and even death. Next slide. So now I'm going to turn it over to Dr. Gurvich, who's going to talk about medications that can contribute to falls in regard to mental health.
Thank you, Dr. Sagel. So I'll have a few slides just to share with you, talking specifically about medications that can contribute to falls. And this, the table to the right of on the slide is taken from the Beers criteria, and this is the list of anticholinergic medications that we know cause cognitive impairment, but they can also cause dizziness and contribute to falling. So, I don't know if you can see because it's a pretty small font, but there's lots of things on this list. Antidepressants, we all know tricyclic antidepressants are bad to use in seniors, but paroxetine is on this list with a little bit of anticholinergic activity. All the antimuscarinic medications for incontinence or irritable bowel are on this list. Things like promethazine, which we use for cough, is on this list. Muscle relaxants are on this list. All the over-the-counter medicines that generally patients don't tell us about are on this list. So when you have a patient who presents with a history of falling, you really do want to look at very carefully at the medications, particularly those with anticholinergic activity, to see if you can get rid of any of them and really make a significant impact on this patient's health going forward. The other thing you have to consider is that one anticholinergic drug can cause a certain amount of dizziness, but 2 or more can cause more. So you're also looking for combinations of these drugs that in total will increase the risk of falling quite significantly. The other drugs that often we associate with falling are obviously benzodiazepines. Even the short-acting ones can cause dizziness the following day if they're taken for sleep, for example, or throughout the day if they're taken for anxiety. The non-benzo hypnotics, I think we touched on that last time we met, but those two can contribute to the risk of falling. And again, all muscle relaxants, not just those with anticholinergic activities, but all of them as a class can contribute to falling. Next slide. So this is the Beers criteria. This is taken from the Beers criteria and just hyper focusing on falls. So fall history and syncope are linked to a number of drugs, anticonvulsants. So things like, gabapentin, Lyrica can cause dizziness. So that's why if you're using them for maybe chronic pain or fibromyalgia, you really want to administer more of it in the evening or at bedtime so that they can sleep through a lot of the dizziness. The antipsychotics, even the atypical ones like Seroquel that we use a lot in the older adults at low doses, one of its side effects is orthostatic hypotension, and it's not insignificant. So even at low doses, it can sometimes cause dizziness. Obviously, the Z drugs and the benzodiazepines, we already talked about that, tricyclics, but also, SSRIs, SNRIs, and mirtazapine are all on the Beers list for the risk of falling and syncopal episodes. So that's another reason to really reduce the starting dose and really monitor patients carefully as we titrate up to effect. Cholinesterase inhibitors that we use for dementia, one of its symptoms is dizziness. We were just on a call the previous hour where someone was experiencing dizziness and was on low dose donepezil. And so the issue is, are they cognitively impaired? Do they need to be on donepezil? Is it a medication related kind of cognitive decline? And so sometimes drugs that we use to improve cognition will cause dizziness as well. Alpha blockers, these are primarily things like terazosin, prazosin, some of the older antihypertensives that we generally don't use a lot of. Occasionally I still see them, so that's important to remember that they can cause falling. And so if you do give them all at night. But also the ones that are primarily used for BPH, like Flomax, tamsulosin, that can also cause dizziness, less so than some of the older alpha blockers, but it can still cause it. So again, use it very carefully in older patients, always give it at night, and monitor patients carefully as we increase the dose. And again, muscle relaxants are also a problem for the same reason. When we're managing pain, we're now told to use fewer narcotics and more adjuvants. Well, the trick is to use them and not cause a fall, because sometimes these cocktails of a little, Norco and a little gabapentin and a little duloxetine all together can potentially put the patient at risk for falling again. So that's why the dosing considerations are paramount in these patients, and you really want to start with the lowest dose and give them in the end the lowest effective dose. So the fewer drugs are in these cocktails, the better. Next slide. So this is a slide showing that really when you have polypharmacy, you're really increasing the risk of falling, and the more drugs you're on, the more likely you are to fall. So if you're dealing with less than 4 medications, the risk of falling is significantly less than if you're using a list of 10 or more meds. So going through the med list when you have a patient with a history of falling is really important. In our clinic, one of our attendings does a falls clinic, and she will often email me the list of patients she's seeing the following day, so I can quickly review the med list, sometimes talk to the patient about it, sometimes not, and just point out those meds that can increase fall risk to see if they can be, the doses can be reduced or they can be discontinued. Next slide. And this is a slide kind of showing that not only high-risk meds can lead to falling. So antihypertensives put patients at risk for falling. Diuretics sometimes can as well, less than general antihypertensives, but they can still do it. Beta blockers can sometimes do it. Obviously, actually on this slide, narcotics are not as prominent on in terms of fall risk as some of the others, but look at non-steroidal anti-inflammatory meds, 1.21 odds ratio. So they too, this group of medications can also contribute to falling. And on the other side of the slide, I have, again, other things that can potentially be a problem. So obviously alpha blockers we've already discussed, anticholinergics, again, oral hypoglycemics, and hypoglycemics in general, insulin as well. If the patient is being too aggressively managed for their diabetes, that can potentially cause them to get dizzy and fall if they're hypoglycemic. Again, go over the over-the-counter meds and herbal products, antihistamines, sleep aids, definitely can increase that risk. I think that's the end of my slides. Next slide. Yep.
Yes, thank you, Dr. Gurvich. So in terms of the goals of management for our patients who may be experiencing depression or depressive symptoms, we really want to obviously use our pharmacological tools when appropriate, but we also want to maximize the use of psychotherapy, physical health, and function. I think it's also important to foster social support and address any social determinant of health issues such as financial insecurity and food insecurity, which in our older patients has been shown to lead to depression and depressive symptoms. So I think when we look at mobility and mental health, and we take a comprehensive global look at that, our treatment strategy should really be to marry the pharmacotherapy and psychotherapy approach while also maximizing social and emotional support for our patients. I'm going to leave it there and open it up to questions if anyone has something for us.
I had a question for Dr. Sehgal. This is Jeff Wong, UCI. You said that you look closely at decreased function due to physical diseases versus is it due to mood? How do you distinguish to qualify as a criteria for depression, like fatigue or psychomotor retardation, to diagnose depression and not simply due to physical disease? Thank you.
That's a great question. Thank you for that. So I look at symptoms on a continuum. And if I know that someone, for example, I wanted to understand what their I don't want to say pre-morbid, but pre-depressive function was, I want to look at that and I want to compare that to their function and mobility as the depressive symptoms have started and are moving on. So that's one way. Two, I want to understand if the mobility issues are related to an underlying health condition, such as Parkinson's disease, where that might be very overt and characteristic of the Parkinson's disease, or related to something else. So I may not be able to tease apart 100% what's coming from the mental health versus the actual underlying condition, but I want to look at things on a continuum and compare I want to compare symptoms before the depression and then during. And certainly as we're treating the depression, I'm going to hope that whatever mobility or ADL issues the person has acquired, I want to slowly look and see if those things are improving. So for my patient, for example, who unfortunately is experiencing this catatonic phase with severe depression, we've tried, and I am his psychiatrist, we've tried multiple medications, both SSRI, antipsychotic, other mood stabilizers, and his function is not improving. However, we know that prior to him falling into this situation, he was a very functional individual. And we know that through brain scans and MRIs that there is no focal lesion that's contributing to his depressed mobility. So we're looking at all of that. And unfortunately, in that person's situation, because of the lack of effect on medications, we're now looking at ECT to see if we can get him out of this. So I look at continuum and pre and post treatment. Thank you.
Are there any other questions for Dr. Sagal or Dr. Gurevich?
I guess I had a question for Dr. Gurevich. It's kind of similar of teasing these things out, which is regarding, when people fall, you mentioned that you're really careful with looking at the medications to treat pain, for example, but then sometimes people say, I fell because I had pain. And so can we be too conservative with the pain medications? It seems like we're in a rock and a hard place.
We are absolutely. We're absolutely between a rock and a hard place. I think the trick is to come up with a cocktail that uses as low a dose as possible of all the medications. And you really have to, there's not a good answer for this. You have to look at very patient specific kinds of issues. So, starting an anticonvulsant like Lyrica or gabapentin may be appropriate. Again, using tiny doses, 100 milligrams of gabapentin at bedtime or 25 milligrams of Lyrica at bedtime, and kind of titrate up gradually. I think the biggest difference between a geriatrician's approach to this and say a pain management approach to this is dosing. We often send our patients to pain clinic and they come back on gabapentin 300 TID to start with, and they have already fallen by the time they see us. So again, dosing is really important. Sometimes narcotics are really helpful and sometimes they do relieve pain, but you have to kind of track that and make sure it is effective and these things aren't being abused. And sometimes when you start an adjuvant, you are able to reduce the use of narcotics a little bit more. And, again, like using a duloxetine for pain and depression or fibromyalgia and depression may be an appropriate strategy. So again, using duloxetine at 20 milligrams or 30 to start with once a day to see how they do. Maximizing the use of something like Tylenol. Some people don't use it enough. And I've had good experience with just if patients actually listen and increase their Tylenol to 1 gram 3 times a day, using it daily, that really can take enough of an edge off to be able to use some of the systemic medications less. Using the topical meds can also be sometimes effective. So just kind of using that kind of an approach can be helpful. Does that answer your question? Okay.
Can I just add one thing? So, I feel very fortunate that Dr. Gurevich works in my office, and we will often send patients to her to talk about adjunctive treatments to manage pain, such as she just mentioned the topicals, but also like steroid injections or joint injections that might get someone out of pain even temporarily, physical therapy, working with PM&R. And then also like biofeedback, guided imagery for people that have chronic long-term pain.
Okay, looks like we can move on into our case presentation. Thank you so much, Dr. Gurevich and Dr. Sagal. And if anybody has any additional questions, please feel free to type them in the chat, and I'm sure Dr. Gurevich or Dr. Sagal can answer them via chat. Our case presentation is going to be presented by our very own NP, Camille Fitzpatrick. So I'll go ahead and share that case, and I did send it in advance, so some of you might have seen it. So let me go ahead and pull that up. And Camille, we can go ahead and give a quick overview of the case before we can go ahead and move into discussion.
Okay. Well, welcome everybody. I'm just going to briefly describe our clinic before I talk about the case. We have a continuity clinic or a geriatric consult clinic at in Santa Ana for our family medicine residents and our nurse practitioner students. This is an interdisciplinary clinic which meets once a week. It started, I think, in 2015 when we first had our first GWEP. And we originally started it with annual wellness visits, which then progressed to adding memory evaluations. These patients are referred from the residents in their continuity clinic, as I said, and from the faculty. So again, this is a consult clinic, very specific. This case, however, is unusual in the sense that we have seen this patient over and over again, which makes it a little bit different. So she is a 83-year-old Hispanic female with no formal education. She was born in Mexico. She moved here in 2018 after her daughter noticed a black lesion on her foot. And so she came up here for some treatment. She lives with her daughter. She has 7 children. And most of the time she, as I said, she was living in Mexico. She has no formal education, which is important to know. Her medical problems are many. The biggest one is she has uncontrolled hypertension with multiple hospitalizations. She has cognitive changes, anxiety, depression, insomnia, diabetes. She's on dialysis 3 times a week. She has atrial fib, and all of these are being treated in some way. Additionally, her medications are enormous. She's on, I think we have the med list that I attached. She's on 13 medicines. And as of the other day, we added another one, shame on us, number 14. So we'll discuss all of this. The reason I chose this case again is because it is unusual, but not that we're so much afraid of a mobility issue here, but last week we talked about depression and anxiety, insomnia, and this patient has all of those along with her memory issues. And so I needed to ask Dr. Geriatrics for help with this case. So I'll try and present her over the times that we've seen her. We initially saw her, if you can believe this, in August of 2018 for just an annual wellness visit. And at that time, her family thought that maybe she wasn't quite as sharp as she had been, but she was able to do everything herself. We did a geriatric depression scale on her, which was 5, so a little, and Cassie on her was an 18, which is a little bit low, but again, she had no formal education. She was not walking very much because she had just had surgery for a melanoma. And so we recommended to just kind of do some routine labs, order some PT, follow her along, and see her in a year for another annual wellness visit. And if we had to see her sooner, we could. So then over the next couple of years, she really had a lot of issues with her melanoma, and we didn't see her again. But in April of 20, at the beginning, or I guess at the beginning of the pandemic, she was seen in our continuity clinic. And she was seen for follow-up in hypertension. She had uncontrolled hypertension with dizziness, increased confusion with memory changes, also new kind of vomiting. So again, since this was a continuity clinic, the resident referred her to geriatrics for a wellness visit and maybe a cognitive assessment. So several days later, she actually did get to see one of our Spanish-speaking residents, which was wonderful. And it was the first time we had actually seen her since 2018. But this again was a telemedicine visit. So it makes things a little bit difficult. Fortunately, as I said, this resident was Spanish-speaking. Her issue at that time was she was having 2 weeks with confusion, forgetting things and days. Normally, she had a very good memory. She was sharp. The change seemed abrupt to the family. She may forget that she's going to dialysis. She wasn't going out except for, no, she wasn't going out at all, obviously, during the pandemic, plus for dialysis. There had been no significant changes in any of her ADLs or IADLs. She had no falls, no weakness, no anything. She did, however, have a 3-pound weight loss. Her geriatric depression scale at that time was only 3. Her CASI had decreased a little bit, maybe by 15. She did at that time have a little bit of mood change, meaning she was sad. Her husband had died about 8 months previous. She had a little bit of insomnia, and she did have some change in balance. She had some dizziness, but that was it. And so our assessment at that time is she had an abrupt report of memory changes. We felt that this could be, she had also just recently gone on Fosamax, by the way. And so what we felt like, again, this was a telemedicine visit that maybe we really needed to see her in person for a good physical, but we would take her off the Fosamax and no other treatment at this time. We thought, again, this is vascular dementia most likely. She had had a prior MRI that had been negative. And so we really did not make any major changes on her. Then in July, we had another telemedicine visit. So we have not seen this patient in person yet. She came in for just a follow-up visit. And what had happened was she had in the last 2 months, she had been hospitalized 4 times for blood pressure uncontrolled into the 200s. And in in May, she had had a recent stroke. So she, at this time, she seemed a little bit confused, especially when her blood pressure was high. It seemed to happen when she was in dialysis. And again, kind of unclear about some of her memory. She denied repetition of questions or conversations, and her CASI at that time was 5, so not very much different. But her geriatric and her geriatric depression scale was 5. I'm sorry, her CASI at that time was 5, so it had decreased from 15, and originally it was at 18. Again, we have to wonder though how much she is really getting over the phone with somebody who is not Spanish speaking but using an interpreter. So she had a recent CVA, as we said, and so we recommended to the daughter that we encourage her to do as much of her maintaining independence. We'd get her some physical therapy. We really recommended that her blood pressure be managed. We are not doing that in this clinic. We also discussed, we had a advanced care planning counseling discussion, and we considered her going to the PACE program. So the next time we saw her was this year, January, and this was the first face-to-face visit that we had had with her. At that time, this was for actually a memory evaluation. She had been just recently hospitalized January 5th to January 11th due to memory issues, according to her daughter. She had been confused, she had abnormal body movements, and so she was hospitalized. At that time, she was placed on Seroquel, clonidine, hydralazine, and they had increased her dose of daltiazem from 30 milligrams twice a day to 60 milligrams 4 times a day. So during this visit, the resident noticed that she indeed was repeating questions. She didn't seem to be able to, she had divided attention. She had, her eye-hand coordination was a little bit slower. She seemed to have difficulty with planning. She did have difficulty with change in strength, change in balance, and behavior. She seemed to have some paranoid thoughts, some insomnia, and some mood changes. And she needed help with most of her ADLs. Her blood pressure that day was 124/36. The CASI was a little bit better. It was 10. And again, the geriatric depression scale was 5. She appeared in no distress. She was alert. She was oriented. She had some diminished and slow finger tapping. She was slow in her gait and had diminished arm swing, sorry. She had a recent PET scan because again, she had malignant melanoma and there was no evidence of any kind of metastatic disease. So at that time, our recommendations were that she definitely has vascular dementia. Does she have a component of Alzheimer's? Not sure. We considered mild depression. We recommended stopping the Seroquel and the clonidine. And we started her on a little bit of melatonin because we were addressing her sleeping. We considered starting Remeron, but we wanted to wait until the next visit. And again, we talked about maybe she would be a good candidate for PACE. So that was in January. And then in February, she came back to the continuity clinic and the resident at that time said that she was appearing very anxious. She had intermittent confusion and memory issues. And the blood pressures had been going up to the 200s on a daily basis. She had taken clonidine once a day at home daily. And her blood pressure today was 173/50. So they sent her back to us and they actually did start her on a Remeron 0.5 milligrams, 0.5 tablet of 7.5 milligrams. And so at this point, she was coming back to us because the resident sent her back to geriatrics. And when I saw that she was coming in this week, I emailed Dr. Gervitz and I said, Tanya, we need help on this patient. She's anxious. She looks like she's depressed. She's confused. Her blood pressure is out of control. We need some help. Can you help us out? And actually, we've got a fourth-year medical student, Axana, who is on the call with us. And so, Axana, if you want to add anything, either before or after Dr. Gervitz speaks, go right ahead.
Well, thank you. Yeah, no, you've been very, very thorough. I think that yeah, I think that the only thing was kind of what you said about the
Okay, it's not in the
native
box.
language. I think
Okay.
that made a difference for her.
Okay.
Thank you. Dr. Gervitz? Oh, you're muted.
Sorry, I was answering a question in the chat.
Oh, I'm sorry.
That's okay. So when we last spoke, I think we initiated Buspar, right?
Correct. So when she came in on Wednesday, what we did at that point was again, this was a telemedicine visit again, unfortunately. And so she was really complaining of anxiety and insomnia during that visit. So what we did was increase the Remeron actually. She seemed to be more depressed, and we did start the Buspar just once a day to begin with. And then, you know, obviously sent her back to take care of the blood pressure because we're not taking care of that. Oh, by the way, her geriatric, the anxiety scale was 9. It had been 3 previously.
So the thing with Buspar, it doesn't work quickly for anxiety. You have to kind of work with it, increase the dose as tolerated, and it's just wait a little bit to see what the effect of any given dose is. So it's sort of a long-term strategy. But you know, we use it at the Senior Health Center fairly often with some success. So that's maybe, you know, I think we need to wait and see whether or not this is effective.
Right.
But
Thank you. So we'll see. I mean, she really was still, she was going to bed at 7 or 8. She was waking up at 4 so she could have her kidney dialysis on the days that, you know, she also woke up at 2 or 3. She slept for 20 minutes, 20 to 30 minutes at the time she had dialysis. So the combination of days when she has dialysis and days when she doesn't, her sleep is just, it's just not good. So, any help from anybody else or any questions?
Camille, I just wanted to know, what's her level of functioning? I mean, is she independent? Is she alone?
So she lives with her daughter, and she can do most of her basic activities of daily living, but she doesn't do the others. And she just hangs out all day.
And is she open to social activities? I mean, I like the PACE referral. I thought that was really smart. But if she doesn't enroll in PACE or they won't accept her, is she open to going to a day program?
I think when it opens, when they open, yes. She had been active prior to the pandemic, and she was active. But then, of course, her foot was also an issue, you know, with the melanoma. It was pretty extensive. She had had surgery, and then she needed more surgery, and then she declined. So, I mean, I think for me, we want this patient to have the best quality of life that she has remaining. The pandemic has really not helped.
Absolutely. But I will say that one of my patients who does attend a day program, his program opened up. And they're requiring a negative COVID test and vaccinations. But he started his program, I think yesterday.
Perfect. So I think we might bring up PACE again to her and see.
Yeah.
Does anybody have any questions or would like to weigh in on the case with Camille? Camille, did you get your questions answered?
I think so. Oksana, how do you feel about it?
Sorry, I'm in a place with some noise currently. What was the question? I'm sorry.
I said, do you feel comfortable with her now with the adding the Remeron and starting the Buspirone?
I think that could be helpful, and hopefully, as you said, hopefully we can see her in person, because I know that the fact that she was over the telephone that made a difference, and it would be much beneficial to be able to see her in person, hopefully.
Okay, thank you.
No, it was like, okay, this is Beatrice Vidas from UCI. I have a question. You said, Camille, you mentioned that before the pandemic, the patient was active. Are there any activities that maybe the family can safely re-engage her in, or any of her, if she has any grandchildren that can help to engage her in those activities in a safe way?
Mm-hmm. I don't know the answer, Beatrice. I've never seen her face to face. So another challenge.
Okay, thank you all. And thank you, Camille, for submitting the case. It might be a case we want to follow up on at another session, but thank you so much. Let me go ahead and share my screen again so we can close out the session. I know we're running out of time. Just to close out, I will be sending an email to you all with the CME form and the session evaluation. So you'll receive that in a few minutes with the presentation we had earlier by Dr. Gerbich and Dr. Sagel. CME certificates and HB certificates should be sent to you at the end of the series as well. Our next session is going to be taking place in 2 weeks on March 5th, and the focus is going to be suicidality and elder abuse, which will be presented by Dr. Gibbs. Does anybody have any last minute questions before we end today's session? Okay. It looks like we can close out, but it does look like we have a question or input from Laura. Is the patient family included in her care plan, and has the patient family had any input regarding the patient's care? Camille?
It's just the daughter that she lives with, and the daughter is, I believe, open to PACE.
Okay. Okay. Okay, thank you all so much. We'll go ahead and follow up at another time, and we'll see you in 2 weeks. Thank you guys so much for joining today, and stay warm out there.
Thank you.
Bye.